Uh, Hi guys, my name is Mayank Kumar and I am going to talk a few things about a chapter from the pharmacology, that is respiratory system. First topic is are the drugs used in the treatment of cough. Cough is a protective reflex intended to remove irritants and accumulated secretions from the respiratory passages. The drugs used in the symptomatic treatment of cough are first are the antitussives, which are codeine, fluocodine, nosocapine, dextromethorphan, prenoxidazine, and antihistamines. Second are the pharyngeal demulcents, which are lozenges, linctusses, licorice. Third are the expectorants, which are sodium and potassium citrate, potassium iodide, guaifenesin, and ammonium chloride. Fourth are the mucolytics, which are bromhexine, acetylcysteine, carbocysteine, and ambroxol. Cough may be a productive cough or a non-productive cough. Okay, so productive cough helps to clear the airway. Suppression of productive cough is harmful as it may lead to infections. Treatment includes antibiotics for infection, expectorants, and mucolytics for cough. And non-productive cough should be suppressed. So first we're gonna talk about antitussives. They inhibit cough reflex by suppressing the cough center in the medulla. They are used for the symptomatic treatment of dry, unproductive cough. Antitussives should be avoided in children below the age of 1 year. Okay, so the first antitussive is codeine. It has cough center suppressant effect. It causes mild CNS depression, hence drowsiness can occur. Third, it causes constipation by decreasing intestinal movements. Fourth, it should be avoided in children and asthmatics. Codeine is administered orally, has mild analgesic effect and less addiction liability than morphine. Okay. Second antitussive is folcodeine. Its antitussive action is similar to codeine. It has no analgesic or addiction liability. It is administered orally and has a long duration of action. Okay. Third antitussive is noscapine. Noscapine, an opium. It is an opium alkaloid and has potent antitussive effect. It is useful in spasmodic cough. It has no analgesic effect, doesn't cause constipation, addiction, or CNS depression. Okay, the side effects are nausea and headache. Bronchospasm can occur in asthmatics. Okay, fourth antitussive is dextromethorphan. It is a centrally acting antitussive agent. It has no analgesic property, does not cause constipation and addiction. Mucociliary function in respiratory passages is not affected. It may cause sedation and hallucinations. Fifth antitussive is antihistamines like diphenhydramine, chlorpheniramine, promethazine, etc. They are useful in cough due to their sedative, anti-allergic, and anticholinergic actions. They produce symptomatic relief in cold and cough associated with allergic conditions of respiratory tract. The sixth and last antitussive is prenoxidazine. It acts peripherally on stretch receptors on the airways. Okay. Next come the pharyngeal demulcents. Okay. Syrups, lozenges, linctusses, or licorice may be used when cough arises due to irritation above the larynx. They increase salivation and produce protective soothing effect on the inflamed mucosa. Syrup is a concentrated solution of sugar containing the drug to mask the bitter taste of the drug. Okay. Lozenge, solid dose form placed in the mouth and sucked. It dissolves slowly to liberate the active ingredient. It soothes the irritated mucosa of the throat. Example, diclonine. It is a local anesthetic for sore throat. Okay. Linctus, a viscous liquid, slipped slowly to allow it to trickle down the throat. Used for relief of cough. Example, Linctus codeine. Next are the expectorants or mucokinetics. They increase the volume of bronchial secretion and reduce viscosity of the sputum. Hence, cough becomes less tiring and productive. They include iodides, chlorides, bicarbonates, acetates, volatile oils. Okay. Next come the mucolytics. These agents break the thick tenacious sputum and lower the viscosity of sputum so that the sputum comes out easily with less effort. Okay. Next are the bromhexine. It is a semi-synthetic agent used orally. It has a potent mucolytic and mucokinetic effects. Uh, Bromhexine liberates lysosomal enzymes which digest the mucopolysaccharides and decreases viscosity of sputum. Okay, and the cough becomes less tiring and productive. Okay, and the side effects of bromhexine are rhinorrhea and lacrimation. Okay. Next group are acetylcysteine and carbocysteine. Acetylcysteine is a mucolytic used as aerosol in the treatment of cough. Acetylcysteine and carbocysteine, they open disulfide bonds in mucoproteins of sputum, so sputum becomes thin and less viscid, and the cough becomes less tearing and productive. Okay, the side effect of these are nausea, vomiting, and bronchospasm. Carbocysteine is administered orally. It may cause gastric irritation, hence should be avoided in patients with peptic ulcer. Okay, so these are the drugs used in the treatment of cough. Our next topic is drug used in the treatment of bronchial asthma. In bronchial asthma, there is impairment of airflow due to contraction of bronchial smooth muscle, swelling of bronchial mucosa, and increased bronchial mucus secretion. There is inflammation and hyperresponsiveness of airways. Several factors may precipitate attacks of asthma in susceptible individuals. They include allergy, infection, and psychological factors. The airway obstruction in asthma is mainly due to the release of mediators from sensitized mast cells in the lungs. They are histamine, serotonin, prostaglandins, leukotrienes, proteases, platelet activation factor, etc. Bronchial asthma may be either episodic or chronic. Okay, so first is the acute asthma. It is characterized by episodes of dyspnea associated with expiratory wheezing. Second is chronic asthma. There is continuous wheeze and breathlessness on exertion. Cough and mucoid sputum with recurrent respiratory infection are common in chronic asthma. Third condition is status asthmaticus, or also known as acute severe asthma. When an attack of asthma is prolonged with severe intractable wheezing, it is known as acute severe asthma. Okay. Now, some anti-asthmatic drugs are classified into bronchodilators, and it includes three categories: sympathomimetics, methylxanthines, and anticholinergics. Sympathomimetics include selective beta-2 and adrenergic agonist like salbutamol, terbutaline, pambuterol, salmeterol, and formoterol, and non-selective like adrenaline. Methylxanthines include theophylline, aminophylline, etophylline, and doxyphylline. Anticholinergics include ipratropium bromide and tiotropium bromide. Second class is leukotriene receptor antagonists. They include gefileucas, montelukast, xylitol. Third are the mast cell stabilizers. They include sodium chromoglycate and ketotifen. Okay, ketotifen. Fourth category is of glucocorticoids, which include inhaled glucocorticoids and systemic glucocorticoids. Beclomethasone, budesonide, fluticasone, and cyclosonide. They come under inhaled glucocorticoids. And hydrocortisone, prednisolone, methylprednisolone, they comes under systemic glucocorticoids. And the fifth category is anti-IgA monoclonal antibody, which includes omalizumab. Okay. Now we start with the mechanism of action of sympathetic mimetics from the bronchodilators. Sympathomimetics act by stimulating beta-2 receptors in the bronchial smooth muscle and mast cells. It increases the cyclic MP, which lead to bronchodilation, inhibition of release of histamine and SRSA from mast cells, and promote mucociliary clearance. Okay. The next is selective beta-2 agonists. In sympathomimetics, there is selective beta-2 agonists, which are salbutamol and terbutaline, salmeterol and formoterol. Salbutamol and terbutaline is a selective beta-2 agonist, and salmeterol is a long-acting selective beta-2 agonist, and formoterol is a long-acting selective beta-2 agonist. Okay. The next category is of adrenaline, which is a non-selective sympathomimetic. It produces prompt and powerful bronchodilation by acting through beta-2 adrenergic receptors. It is useful in acute attack of asthma, which is not responding to other drugs. 0.2 to 0.5 ml of 1 is to 1000 solution given subcutaneously. Its use has declined because of its dangerous cardiac side effects. Next is selective beta-2 adrenergic agonists. They are the first-line drugs for bronchial asthma. Okay, they are well tolerated when inhaled. They may cause tremor, tachycardia, palpitation, hypokalemia, and rarely cardiac arrhythmias. Barbuterol is a prodrug of terbutaline. It is administered orally once daily dose is used, and it has longer duration of action. Methylxanthines are used in asthma has markedly diminished because of their narrow margin of safety and availability of better anti-asthmatic drugs like selective beta-2 agonist, inhaled steroids, and leukotriene antagonists. Methylxanthines act by inhibiting phosphodiesterase, which increases cyclic MP and lead to bronchodilation, inhibition of release of histamine, and improvement of mucociliary clearance. Okay. Methylxanthines inhibit phosphodiesterase, okay, thereby increase CAMP. Next, pharmacokinetics. Methylxanthines are well absorbed after oral and parenteral administration. Food delays the rate of absorption of theophylline. They are well distributed all over the body, cross placental and blood-brain barriers. They get metabolized in the liver and excreted in urine. Theophylline. It is poorly water-soluble, hence not suitable for injection. It is available for oral administration. Aminophylline. It is water-soluble but highly irritant. It can be administered orally or slow intravenously. Etophylline. It is water-soluble and can be given by oral IM or IV routes. And the next is toxophylline. It is a methylxanthine derivative. It is orally administered once or twice daily dose is used. Less likely to cause GI and CNS side effects. Adverse effects of methylxanthines. They have a narrow margin of safety. They can cause tachycardia, palpitation, hypotension, and sometimes sudden death due to cardiac arrhythmia. Okay. And now drug interactions. Sympathomimetics and methylxanthines. Methylxanthines potentiate the effect of sympathomimetics, like bronchodilation and cardiac stimulation. Now, bronchodilation is the beneficial effect, but cardiac stimulation is the harmful effect. Second is interaction of phenytoin or rifampicin or phenobarbital with theophylline. They are enzyme inducers, hence they accelerate the metabolism of theophylline and decrease its effect. And the next interaction of theophylline is with cimetidine, ciprofloxacin, or erythromycin. These are enzyme inhibitors, hence potentiate the effect of theophylline by interfering with its metabolism. Uses of methylxanthines. Methylxanthines are used in bronchial asthma and COPD and apnea in premature infants, where theophylline is used as an additional drug in moderate or severe persistent bronchial asthma. And in case of apnea, theophylline is used orally or intravenously to reduce the duration of apnea episodes. The next category is of anticholinergics. Ipratropium bromide and tiotropium bromide are atropine substitutes. They selectively block the effects of acetylcholine in the bronchial smooth muscle and cause bronchodilation. They do not affect mucociliary clearance. They have a slow onset of action and are less effective than sympathomimetic drugs in bronchial asthma. These anticholinergics are the preferred bronchodilators in COPD and can also be used in bronchial asthma. They are administered by inhalation route and act primarily on large airways. Combined use of ipratropium with beta-2 adrenergic agonist produce greater and more prolonged bronchodilation, hence used in acute severe asthma. The next category is of leukotriene antagonists. These drugs competitively block the effects of cysteine leukotrienes LTC4 and LTT4 on bronchial smooth muscle. Okay. Thus, they produce bronchodilation, suppress bronchial inflammation, and decrease hyperreactivity. They are well absorbed after oral administration, highly bound to plasma proteins, and metabolized extensively in the liver. They are effective for prophylactic treatment of mild asthma and moderate persistent asthma. They are well tolerated, produce few adverse effects like headache, skin rashes, and rarely produce eosinophilia. The drug Xylitol. Xylitol inhibits 5-lipoxygenase and is administered orally. It is hepatotoxic, so it is restricted in use. The next category of drugs are mast cell stabilizers. Sodium chromoglycate and ketotifen are mast cell stabilizers. They are not bronchodilators. They inhibit the release of various mediators like histamine, leukotrienes, prostaglandins, platelet activation factor, etc. by stabilizing the mast cell membrane. They also reduce bronchial hyperreactivity to some extent, but the antigen-antibody reaction is not affected. Onset of action is slow. Sodium chromoglycate is not effective orally as it is poorly absorbed from the gut. In bronchial asthma, sodium chromoglycate is given by inhalation. Now the uses of mast cell stabilizers. They are used in allergic asthma as a prophylactic agent to prevent bronchospasm induced by allergens and irritants. It can also be used in allergic conjunctivitis, allergic rhinitis, allergic dermatitis by topical route as a prophylactic agent. Okay. Now the adverse effects of mast cell stabilizers include mainly systemic side effects are rare and it can cause symptoms of local irritation like cough, bronchospasm, headache, nasal congestion, etc. The drug ketotifen. Its mechanism of action is similar to sodium chromoglycate, has additional H1 blocking effect. It is orally effective but has a slow onset of action. Okay. Now the next group is glucocorticoids. Glucocorticoids include two categories. First one is systemic, which include hydrocortisone, prednisolone, methylprednisolone, and the second one are inhalational, which include beclomethasone, budesonide, and fluticasone. Okay. Glucocorticoids induce synthesis of lipocortin, which inhibits phospholipase A2 and thereby prevent the formation of various mediators such as prostaglandin, TXA2, SRSA, etc. Glucocorticoids have anti-allergic, anti-inflammatory, and immunosuppressant effects. They suppress the inflammatory response to antigen-antibody reaction. They decrease mucosal edema and also reduce bronchial hyperreactivity. Glucocorticoids do not have direct bronchodilating effect, but they potentiate the effects of beta-2 adrenergic agonists. They also prevent development of tolerance to beta-2 adrenergic agonists. Inhaled glucocorticoids such as beclomethasone, budesonide, fluticasone, and cyclesonide are used as prophylactic agents in bronchial asthma. Cyclesonide is a prodrug. It gets activated by esterases in bronchial epithelium. They are well tolerated. Systemic side effects are minimal with these agents. The common side effects are hoarseness of voice, dysphonia, and oropharyngeal candidiasis. This can be reduced by using a spacer, rinsing the mouth after each dose, Oral thrush can be treated effectively by topical antifungal agent nystatin or hemicin. Combination of long-acting beta agonist with steroid is available. Example fluticasone plus salmeterol or budesonide plus formoterol. They have synergistic action used in bronchial asthma and COPD. They are used in moderate and severe persistent asthma. Systemic glucocorticoids are used in acute severe asthma and chronic severe asthma. Long-term use of systemic steroids produce severe side effects such as gastric irritation, sodium and water retention, hypertension, muscle weakness, osteoporosis, HPA excess, hypothalamic pituitary axis suppression. Okay. The next category is anti-IgA monoclonal antibody, that is omalizumab. Omalizumab prevents the binding of IgA to mast cell, thus prevent mast cell degranulation. It has no effect on IgE already bound to mast cells. Okay, it is administered parentally. It is used in moderate to severe asthma and allergic disorders such as nasal allergy, food allergy, etc. It is approved for use in patients about 12 years of age. It causes local side effects such as redness, stinging, itching, and induration. The next is inhalational devices. They are metered dose inhaler (MDI), can be used alone or with spacer devices. Second is dry powder inhalers like Spinhaler or Rotahaler. The third is nebulizers, useful in acute severe asthma, COPD, and for delivering drug in young children. Anti-asthmatic agents available as inhalants are beta-2 adrenergic agonists, salbutamol, terbutaline, salmeterol, and formoterol, or anticholinergics like ipratropium bromide and tiotropium bromide, or mast cell stabilizers like sodium chromoglycate, and glucocorticoids like fluticasone, beclomethasone, and budesonide. Okay. The next is treatment of acute severe asthma, also known as status asthmaticus. It includes humidified oxygen inhalation. Second step is nebulized beta-2 adrenergic agonists like salbutamol 5 mg or terbutaline 10 mg, along with anticholinergic agent like ipratropium bromide 0.5 mg. Third, we can use systemic glucocorticoids like intravenous hydrocortisone 200 mg IV stat, followed by IV hydrocortisone 100 mg quaternary 6 hour, or oral prednisolone 30 to 60 mg per day, depending on the patient's condition. Fourth, intravenous fluids to correct dehydration. Fifth step is potassium supplements to correct hypokalemia produced by repeated dose of salbutamol or terbutaline. Sixth step can be sodium bicarbonate to treat acidosis, and third we can give antibiotics to, and seventh step we can give antibiotics to treat infection. Now, drugs which should be avoided in patients with bronchial asthma, it include NSAIDs like aspirin, ibuprofen, diclofenac. Paracetamol can be used. Second, we can use beta-adrenergic blockers, and also cholinergic agents should not be used in patients with bronchial asthma. That is all about the discussion on this topic, respiratory system.